presented. So what about the radiographs? Can we say something about this pathology on a radiograph? This is a normal craniocaudal radiograph of the shoulder, where we see the nice alignment of the scapula and the humerus. This one is a one with a contracture, meaning the contracted infraspinatus will contract and will narrow this joint space. The lateral part of the joint will be pulled together. That's something that we can pick up on a radiograph, of course, if we take radiographs of both sides. Also, ultrasound is useful here. This is a sagittal image of the infraspinatus, and often is, when there's pathology present, is that it's more hyper-echogene than normal. So, next image shows also some examples. This is longitudinal muscle, and this image, I'm sorry, and this also longitudinal, where we have the infraspinatus with a heterogeneous echogenicity. This one is a little bit brighter than it should be, and which is the finding on ultrasound. Amount of fluid and darkness, and with small kind of opacity being present as well. So to pick up a contracture on a CT or on a radiograph, we saw it's not that easy, and we recently had a case in the clinic where we could pick up the lesion of the infraspinatus, and this is a transverse image at the level of T1, so the dog is in thoracic positioned, and we have the area of pathology, the normal area. This is the scapulum, of course. We immediately see the muscle atrophy. There's a less amount of muscles present in relationship to this image, and after IV contrast, in CT we use a lot of IV contrast as well, we could pick up the hyperdense contrast enhancement of the tendon and at least the muscle at that area. It's the muscle where pathology is going on. And also on the sagittal reconstructed image, so in this plane a reconstruction is made, we see the hyper density, the uptake of contrast at the level of the contracture. So an avulsion of the supraspinatus, it's also not so obvious to pick up, or at least you have to know where you have to look at. And I have images of both sides of this patient. So this is the right shoulder, the left one, and the craniocaudal views. If we look to this one and compare this area with this one, we immediately see that there's irregular density sclerosis going on. The head of the humerus looks nice. It's still a young animal. In this one, the normal side, the growth plate is still open, and this one is closed, probably due to the fact of pathology in general, or at least here in this area, in this case. We have both craniocaudal views, the normal right one, and this is the left, where we see here some defect surrounded by sclerosis. So it provides very nice CT images, this kind of pathology. In the transverse plane, and we have here both humeral heads at the same level in this image, we see immediately the huge defect we are having here, and that's the area where is the insertion of the infraspinatus. So a little bit more caudally than the insertion of the supraspinatus. This is the soft tissue algorithm. There's no contrast administered here, but you immediately see the swelling and some hypodensity here, which means that there is fluid and soft tissue swelling in this area present. And the reformatted image in the sagittal plane, a huge defect surrounded by sclerosis, and the 3D image, which is even more remarkable, a huge hole surrounded by bone reaction. This is a different case, this and this, where we were even able to pick up a fragment at the level of the avulsion of the tendon. You nicely see it here, the defect of the attachment, which is avulsed and a fragment. Okay, what about the glenohumeral ligaments? And there are nice studies performed. We also performed an anatomic overview or correlation of contrast, intra-articular contrast applied in CT and in MR, and compared it with anatomical images. We can nicely evaluate the glenohumeral ligaments if we know where we have to look at. In the anatomical specimen, this is cranial and caudal, medial and lateral. This is the medial collateral ligament, and this is the lateral collateral ligament. And on the MR image, you see there's contrast applied intra-articularly. It's this small defect in the contrast, a filling defect, because the contrast is running around the ligaments. It's delineating the ligaments. We see here the medial one very clearly, and the lateral one, which seems to be smaller. On CT as well, if we apply contrast, we see the delineation of the lateral glenohumeral ligament and the delineation of the medial glenohumeral ligament. So, as I said, we don't see it that often, pathology at the level of the glenohumeral ligaments. I want to show you this again on MR, the medial one and the lateral one. And I have to look very well. The irregularity we see in the delineation of the medial glenohumeral ligament, irregular delineation, will probably show or lead to the diagnosis of glenohumeral ligament pathology. So, but also in cases when there are fibers, as we saw in the beginning, in inflamed joints, chronic inflamed joints, we will see irregularities at that level as well. And here how it looks like on arthroscopy, a whole bunch of villi, heavily inflamed joint that we are seeing. So this case is the one, and that's one of, actually the only one I can show on CT and on MR, is where we have the irregular delineation of the medial glenohumeral ligament, and here how it should be, how it should look like, sharply delineated. So it's interesting that even those small structures we can visualize, or at least evaluate the delineation on CT and on MR. And here this is the same case, the fibers and irregular villi that were present at the level of the glenohumeral ligament on arthroscopy. Okay, the next part, and we have been talking about flexor tendinopathy already, is about the flexor. And the flexor tendinopathy or flexor affections were first reported in the 60s already, and they were classified under elbow dysplasia in that time. They were rare, they were associated with no clinical findings, so an incidental finding, and a lot of names were given to this kind of condition. Initially, people wrote or published that it was an ununited medial epicondyle. Later on, it was described as avulsion of the flexor of a fragment, not about the flexor tendons, but avulsion of a fragment, or just a fragment at the level of the flexor tendons. And it's now these days that it's really been recognized as being correlated with pathology and lameness. So in recent publications, and we published a lot, we had a PhD student who really described the radiographic findings, the ultrasound findings, CT findings, MR findings of this condition. And it was called, in these days, enthesopathy. It's a term copied from human medicine because they see affections at the level of the attachments of the flexor, so the medial side as well, due to stress in golfers. The lateral enthesopathy is a tennis elbow in humans. The medial, it's not that common, is the golfers. So it's quite similar to what we see here. So why do we call it that way? Because the term enthesopathy refers to the pathologic changes that occur at the level of the attachment and the level of the tendon. It's called enthesitis. The enthesis is the attachment of the tendon to the bone, and enthesitis or enthesopathy, it means pathology. So that's why we call it this way as well, but in the term, no cause is mentioned. So the exact cause of this condition is not known in dogs. That's still a debate. Also in humans, they are not really sure. So here we have some titles of publications. She was the PhD students, and also I was involved, and my colleague. And we actually described a lot about this condition. The difficulty as well in this condition is that it can be primary or secondary. And that's the difficulty. When is a lesion primary, when it's secondary? Because primary, it means that we find flexor findings on or imaging in correlation with a lame dog, and that the coronoid is normal, that there's no OCD and whatever. Often it's in combination with coronoid pathology, and then it's a combinated disease, and we call it concomitant flexor enthesopathy, referring to the fact that there's something else going on in the joint, and the difficulty is the dog lame from, let's say, coronoid pathology or from the flexor? That's still something difficult. About the anatomy, I won't go in detail as we have a whole bunch of flexors in the medial area. So the pronator teres, we have the carpi radialis, and then the carpi ulnaris with two heads, one on the humerus and one on the ulna. In our imaging images we gain, it's difficult to say which flexor is affected. Usually they are all included in the findings. So what are the radiographic findings? In some cases we don't see any radiographic abnormalities. In some cases we find some radiographic findings like a spur, I will immediately show, and then in combination with other elbow pathology, as I said. And then a variable amount of osteoarthrosis can be present in these cases. And the spur, which is a specific finding, the one we saw already in our film reading case. I will show images immediately. And then the irregularity of the delineation, and also in combination with sclerosis at the level of the attachment, and sometimes we find fragments in the flexor tendon and muscle itself, mineralized fragments. So here we have an example. Of a typical spur, which is a skeleton ingrowth of the attachment in the tendon. It can be the only finding. In humans, as I said, it's been correlated due to stress. They also see it in persons. The medial coronoid process looks normal in this image. Here it's worse. We have a spur, and we can't follow the medial coronoid process. So this is a case we can be almost sure there's coronoid pathology present, and a huge amount of arthrosis and sclerosis. Here is just a little bit irregular delineation of the anconeal process. So it can be very discrete, as we see here, a small tip, and it's sclerotic, I have to admit, but still it's very discrete. Coronoid looks normal. So we can discuss about the amount of sclerosis, no arthrosis. On a cranial view, we can pick up some irregularity at the medial side, medial epicondyle, and this is a case, a concomitant case, where we have the irregularity, the irregular delineation. We have an amount of new bone formation in this area, huge sclerosis, and there's no coronoid present. It seems to be gone, so we can be sure that there are fragments in this case. So it can be really discrete, just a small tip, but a typical area, anatomical area is typical. If we see something there, some irregular delineation, here only sclerotic, more sclerotic, so the spur can be the only finding that's important to know. And these are the easy ones where we pick up the mineralized fragments. And if we perform a flexed X-ray of the same, we see the movement of the fragment. So by flexing the joint, the fragment in the tendons will move as well. A small irregularity, small tip, and irregular delineation. So what about ultrasound? Ultrasound can be used, and it's very usable in these cases. What do we pay attention to? It's the outward bowing of the tendons, heterogeneous appearance of the tendons, a loss of echogenicity of the tendons, fluid can be present between the tendons, and thickening of the tendon tissue itself. So I have some examples. This is a normal case where we have the medial epicondyle. It's a longitudinal image, cranial or proximal and distal. We have the delineation and the echogenicity of the different tendons. This is the superficial flexor tendon. This is the flexor carpi ulnaris, and this is the deep digital flexor muscle, and how the normal appearance should be. These three are affected cases. Also longitudinal images, where we see the outward bowing of the tendon, the heterogeneous aspects, small dark spots, hypoechogenicity, overfilling of the joint, this is fluid, thickening of the tendon. This is the flexor carpi ulnaris. In this case, flexor carpi superficialis, this flexor carpi ulnaris. This is the epicondyle. And also here we have an area which is hypoechogene, so meaning that there is a problem at the level of the attachment, and for sure inflamed an amount of fluids. Here again the outward bowing, the flexor carpi ulnaris, where we see the difference in hetero and hypoechogenicity. We miss the attachment and irregular amount of fluids. So also CT is very useful in these cases. We see new bone formation at the level of the caudal-distal medial epicondyle. Sclerotic aspect can be picked up, periostal reaction. We also can pick up the calcifications within the flexor tendons, and easily we can visualize the coronal process as well in those concomitant, combined cases. The thickening can be evaluated, and we often administer IV contrast. IV contrast is very useful in this diseased elbows as well, as I will show immediately. So here we have the different aspects of flexor pathology on CT, the thickening sclerotic area of the attachment, a small area of new bone formation, and these cases go together where we see several fragments at the level of the medial coronoid process, displaced fragments. It's really a very inhomogeneous aspect, also an osteophyte here at the medial side of the ulna, and in this case just a small osteophyte on top of the coronoid process. So probably this can be called a primary lesion, primary flexor-enthesopathy, and this in combination a concomitant flexor-enthesopathy. And then it's still often difficult in these cases to know for sure where the lameness is coming from. Also, the calcifications are nicely visible for sure if we make a 3D image. The calcifications can be quite large. Here a discrete case, some new bone formation at the medial side, sclerosis, and a small calcification in the attachment. So about the application of IV contrast, in those cases there's an inflammation in the tendons and attachments, as we are sure of, as we know. So if we administer contrast, we will see contrast enhancement at the medial side of the joint, the area where the tendons are. Also, the tendons often are really distended, and if we look to those images on different levels, we know for sure that fluid pockets are present as well. The hypo density we pick up on CT is fluid. The contrast enhancement we see, and in this normal elbow, there's just a small amount of contrast that we see, which is normal in a normal case, a normal uptake of contrast. You see here, I see the enhancement of an affected elbow. Why do we see some contrast here? Is because this was an anatomical detail of the attachment of the flexor tendons. There is vascularization at that level. It's not that there are no blood vessels. You see some blood vessels which are normal and present in a normal attachment. So some enhancement will be visible after IV contrast, but these ones, and it can be even more discreet and even worse, the uptake of really inflamed flexor tendons. Here as well, this is also a CT image where we really see the enhancement of contrast in this dorsal reconstruction. We see the attachment also on arthroscopy, and you can say, oh, the attachment is outside the joint, so it's not possible that we see it during arthroscopy. Often in these cases, there is, due to the inflammation and the fibers that are present at the tendons at that level, and they attach at the level of the joint capsule or just run on top of the joint capsule. If you think and imagine. So if they are chronically inflamed and if there are fibers present and an inflammation, they will cause a rupture of the joint capsule. And if you look using your scope and you see the triangle, so they are really looking upwards in the joint, you can see the fibers of the flexor tendons during arthroscopy of the elbow joint. So that's something interesting as well. So a case here with a clear condition of flexor enthesopathy. There's a small fragment in the coronoid area, and what we also do these days is administer contrast in the joint and then do CT. And in those chronic cases where I said that there's a rupture in the capsule, there will be a leakage of contrast outside the joint in the tendon area as well. And this is at the area of the distal unal condyles, medial and lateral. The contrast is delineating the bony structures, it's leaving the contrast and it's running outside the area of the tendons. And you see nicely how the contrast delineates the tendons showing pathology. So that's something useful as well on CT. What about MR? We did studies where we evaluated the flexor tendons on MR as well. In low field, I have to say again, where we described the anatomical findings of the muscles as we see on those sagittal images. What about the MR findings in pathologic cases is if we look to the area, I'm sorry, I'm too fast now, where the arrows are. So we have here the sagittal view of the humerus. We see a part here of the ulna, and the attachment of the flexor tendons is in this area. We see the flexor tendons as being hypo in a normal T2 MR image. In this one, we see the increased signal in between the tendons. There is some irregularity present at the level of the attachment, and here in this image we even see the spur at the level of the attachment with a too large amount of fluid surrounding the flexor tendons. So also on transverse images it is possible to visualize. We also administer contrast in these cases. And this is an image where we have the distal part of the humerus. This is the ulna. This is lateral, medial, caudal, and cranial. And in this area, the flexor tendons attach. So we see too much brightness. This is a T2 image where we can pick up fluid as being bright. And this is the area where the flexor carpi ulnaris attaches. We have the humeral head attaching at the humerus and the ulnar head attaching at the ulna. And it's too distended, too swollen. Outward bowing of the tendons, also in this area, too much fluid. And on the sagittal plane, we see the signal of heterogeneity of the tendons itself with a huge amount of fluid being present surrounding the flexor tendons. This is after the application of gadolinium IV contrast, which almost has the same application as CT IV contrast. We see the enhancement of the thickened area here, so you can be sure you are dealing with an inflamed flexor in that area. So I already talked the difficulties about concomitant and primary. This is an example of a concomitant of a 3-year Bernese mountain dog, where on CT it's easy to pick up the displaced fragment. Besides that, it is a very incongruent joint because the fitting of the ulna in the humeral condyles, which we see here in transverse plane, it's very not even wide, so it's not parallel, so meaning already a small displacement of the humeral condyles, cranially a sign of incongruity. This is irregular delineation with sclerosis. Pick up the fragment, and this is an IV contrast CT image, and you see the huge enhancement with fluid pockets in the medial and caudal-medial area where the flexor tendons are. These are MR images of the same patient, transverse, after IV contrast, a huge swelling, and also on the 3 sagittal planes we can pick up the abnormal appearance of the flexor tendons, the heterogeneous signal in the muscles or in the tendons and between the muscles, even too much amount of joint fluid, and here we are able to pick up a small discrete lesion, which is a huge displaced fragment on the sagittal plane. So that's a hugely inflamed joint, having a large fragment, so probably we would treat both affections in this case. This is a stir image showing the huge enhancement. It's not enhancement in this sequence, it's really hyper intensity of inflamed aspect. And here the appearance of the villi, where the joint is, capsule is ruptured, and where we pick up the inflamed and fibers of the attachment. And this is the fragment at the level of the medial conoid process being removed by a grasping forceps. This is a primary case where there's a small osteophyte present at the level of the medial conoid process, however it's very discrete. There's a huge fragment and new bone formation in this area of the attachment. Again, huge inflammation and swelling after IV contrast. And this is also a 3.5-year-old dog. It's a Rottweiler, where we pick up on the medial side in the transverse MR images nicely the thickening and contrast enhancement of the affected tendons. More in detail here. This is the extensor carpi radialis, and these are flexor muscles. We see in all muscles the heterogeneous delineation, the heterogeneous signal, and also too much fluid being present in these affected flexor tendons. Yeah, I'm running out of time. I'm sorry for that about pathology. I'm not going in depth. Sometimes we remove those fragments, as we see here. Often we just insert the attachment with a kind of anti-inflammatory product, or we even corticosteroids sometimes. So we discussed all that. So it's a condition comparable with human golfer's elbow. A comparison that we see the same findings in the dog. Unfortunately, CT descriptions of these findings in human medicine is not available. MR findings are available in human medicine, and they're